I posted that anonymous snippet of an email from a medical director the other day where he says that the service does too many 12 leads and that repeat or serial 12 leads should only be performed when there is a significant change in the patient's condition or they have chest pain and you have been with the patient for more than 30 minutes or something like that. Then 10 hours later, I walk into work for my shift. I relieve Brandon, the night shift guy, and he presents me with these serial 12 lead EKGs performed 25 minutes apart, where there is a clear progression from an iffy EKG to a glaring STEMI. So I posted these, and as always, there were a couple of comments about how the first EKG is obviously OMI criteria or indicative of something that necessitates a cath lab activation. And I have to say and admit that I don't necessarily agree. I can see it, but well, let's look at EKG 1. And I will say that, yeah, I see a couple of things that could be concerning. But honestly, these things don't mean a whole lot of jack squat according to current protocols, training, philosophies, etc. Like in lead 3, there's maybe a half, maybe a little more if you wanted to be generous, like half millimeter of ST elevation, or I don't even know if you could call it ST elevation, more like an upward skewing of the ST segment. AVF looks a little meh, maybe a pubic hair's diameter of ST skewing. Certainly nothing you can call definitive elevation and something to justify waking up the on-call interventional cardiologist at 3 o'clock in the morning. Maybe there's a little bit of depression in AVL, and maybe there is some depression in V2. What to make of these changes? Well, it depends on the story. Brandon told me that this guy was gray, pale, diaphoretic, and complaining of crushing chest pain. As he put it, screaming that the guy was having an MI. And yeah, story is absolutely fantastic. If I am being honest, that makes me look at these changes with a more discerning eye. If I had this patient, I would think, well, something's probably happening. I'm going to work him up for ACS, but there's nothing here that I can call a heart alert, a code STEMI, or whatever it is your jurisdiction calls it. I would definitely do another EKG in 10 or so minutes to see if there were any changes. And if there were indeed changes, I wouldn't be surprised. But I have to be totally honest because that's the kind of guy that I am. Honest and no bullshit. I will fall on my sword. If this patient wasn't complaining of symptoms that were screaming ACS, like if this was Joe shit the patient with syncope or shortness of breath with some wheezing or abdominal pain, I'd probably notice the subtle EKG changes that we took notice of, but I probably wouldn't have paid it that much attention. And I think that's a good lesson. I think that it is erroneous and honestly kind of naive to take the position that, well, this EKG clearly shows that there is an OMI or an event that requires cath lab activation. I am not being the typical volunteer firefighter here and jerking myself off, giving you my resume, but as someone who has been on the job for over 20 years and trains paramedics, does QA, QI reviews, I've consulted on 2 expert witness cases that specifically involved EKG interpretation. I pick patients up from urgent care clinics, doctor's offices, nursing homes, other aggregate care facilities all the time when I'm on the 911 truck. And on the helicopter, I pick up cardiac patients all the time from ERs going to tertiary care centers. The reason I tell you this and give you this experience is because I do not think that the majority of healthcare providers would identify that this EKG, and I mean this EKG alone, without the context of seeing the patient and knowing the history of present illness, I don't think that a sizable amount of providers, from paramedics to nurses to advanced practice nurses and PAs and internal medicine, family medicine physicians, and even many ER physicians, I don't think they would necessarily identify the concerning changes here. Not all of them, definitely a good amount of them would pick up on it, but I don't think that they're that clear. Call me cynical, It's just how I feel. And I am not pointing fingers or talking shit because I told you that I would probably throw up the old meh emoji if this EKG printed out on one of my patients that wasn't pale, clammy, diaphoretic, complaining of crushing chest pain. And those who work in an ER will probably agree with me that if the ER provider called the on-call cardiologist, 9 out of 10 cardiologists at 3 o'clock in the morning would look at this EKG, text or email, and they would tell the ER doc to call back if and when there are real ST elevations and then slam the phone down. And then we can see here that Brandon did repeat 12 lead EKGs. Very good job, Brandon. The first repeat didn't really show anything, but this 12 lead was 25 minutes later and clearly showed that this patient was having the big one. As I like to say, the environmental services guy, girl, or they, them could tell that this was a big, fat, whopping, inferior, lateral, inferolateral MI. And this V2 right here makes me concerned that there may be some posterior involvement, but that's something that the cardiologist is going to find in the cath lab. Also, take note of the reciprocal changes. Yes, certainly V2 counts, but also AVL. You could see some depression there. And then maybe, yeah, like a millimeter, half millimeter to a millimeter of ST depression in lead 1. And remember, it doesn't matter where the reciprocal changes are. All it matters is that they are there. They confirm your STEMI diagnosis. However, if they aren't present, that doesn't mean that the patient is not having a STEMI, not at all. I tell my students that reciprocal changes are your nail in the coffin for confirming your suspicion that the patient is having a STEMI. So what do I take from this? Serial 12 leads are good. I am not a physician. I'm not an electrophysiologist, but I think that it is irresponsible for a physician medical director to tell his paramedics that they are doing too many 12 leads. Yes, I am the first to roll my eyes at the paramedic who blindly does 14 serial 12 lead EKGs in the everyday patient with whatever symptoms, pick them, and they stare at them and they look at the 12 lead like this, like they're waiting for the squiggly lines to rearrange themselves and manifest changes that just aren't there. However, it doesn't hurt to do the serial 12 leads. The back of the ambulance is not like the ER. It doesn't take any effort. It doesn't take a nurse or a tech away from another important task to do a repeat EKG. It doesn't cost anything extra. It doesn't take the EKG machine away from another patient who may more immediately need it. Uh, If nothing else needs to be done and the medic is just sitting there and wants to cover their bases and repeat a 12 lead, good. Who cares? You never know. You might pick up something that you would have otherwise missed.